Well, I want to go ahead and start our meeting for Thursday, March 9th, and to welcome everyone for coming and to let you know that Tammy's not able to be here today, so I'm driving the car with help from staff and everyone else. Need help to stay on track, but Tammy's not here because she's had a family issue that's come up. But she said to let you know that she'll be back next week on the 13th, and she's keeping us all in her heart while she's away. So why don't we start with introductions, and we'll start with, I'm just going to go straight across by rows and hope that the thing doesn't reshift. So let's start with Whitney and then Camille.
Hi, everyone. My name is Whitney Schumacher. I use she, her pronouns, and I'm a project manager with the Health Council.
I am Camille Smith, and I am also with the Central Oregon Health Council.
Great. Kelly and then Miguel.
Hi, everyone. Kelly Adams, she, her, hers, Health Council admin.
Good morning, everybody. Miguel Angel Herrada, pronouns he, him, L, and project manager of the Health Council.
Welcome, Miguel. Carmen and then Gwen.
Hello, good afternoon, everyone. Carmen Madrid, Executive Director for Central Oregon Health Council.
Hi, Gwen Jones, Project Manager with the Health Council. She, her,
Gary,
hers.
and then Tricia.
Good afternoon, Gary Allen, Vice President Clinical Services, Advantage Dental.
Good afternoon, everyone. Tricia Wilder. I use she, her pronouns, and I'm the CCO Director for Central Oregon for Pacific Source.
Welcome, both of you. Justin and then Megan.
Howdy, I'm Justin Civil. I'm the Chief Operating Officer for Summit.
Hi, everyone. Megan Hayes, she, her pronouns, and I'm with Mosaic Medical. Good to see everybody.
Good to see you too. Dustin and then Leslie.
Hi, everyone. Dustin Zimmerman. I am your innovator agent with the Oregon Health Authority, and I use he, him, his pronouns.
Hi, Leslie Neugebauer from Pacific Source, she, her pronouns.
Welcome, both of you. Rick and then Katie.
I'm Rick Trelevin from Best Care Treatment Services.
Hi, everyone. Katie Plum. I use she, her pronouns, and I'm the Public Health Director in Crook County.
Welcome, Katie and Rick. Divya and then Martha.
Hi, everyone. Divya Sharma. I'm the CMO for Quipa. I handle Pine and she, her pronouns.
Hi, everyone. Martha Edwards, she, her, Aya. I'm the Health Equity Liaison for Central Oregon and the Gorge for Pacific Source.
Great. Welcome, Divya and Martha. Lori and then Jeff.
Hi, everyone. I'm Lori Hill. I'm the CEO for Central Oregon Pediatric Associates.
Hello, I'm Jeff Davis. I'm the CCO Medicaid Medical Director for Pacific Source.
Welcome, Lori and Jeff. Dan and Brad.
Hi, good afternoon. I'm Dan Stevens. I'm with Pacific Source, and I'm our representative on the Health Council Board.
Hi there, him, Community Advisory Council Chair and with Latino Community Association.
Welcome, Brad and Dan. Patty and then Kat.
Good afternoon, Patty Dare, Deschutes County Commissioner. Thank you.
Hi, everybody. Kat Mastrangelo with Volunteers in Medicine.
Thank you and welcome both of you. And Justin and Jeff. Justin and Jeff.
Justin Seville already went.
I think we've both already.
Oh,
Yeah,
the
sorry.
screen is changing then. Then let me ask this. Who did I miss?
Here, I'll
Myself.
chime in. My name is Laura Hart. I'm a public health management analyst from Deschutes County, and I'm in a different space today, which is why I'm off camera, but thank you so much for the invite.
Thank you for coming, Laura. I'm Linda Johnson. I'm Vice Chair and Community Member on the Health Council. So I think the first item of business is to see, is there any public comment that anyone wants to add or comment upon? Not, let's go ahead and proceed with our agenda. First order of business is the consent agenda. And I need a motion and a second. And then we'll take the vote.
This is Gary Allen. I'll move to approve the consent agenda.
Is there a second?
Patty Adara, I'll second.
All in favor, just wave your hands. Any opposition? Motion passed. Next on the agenda, Carmen, do you want to introduce the staff and regional health assessment update?
Sure. We are in a good space now with our regional health assessment update. And really, this is an opportunity to let you know how we have enhanced the project because of we have some leadership here now with Whitney, Miguel, and Laura with Deschutes County, who's present here today. So I am going to go ahead and pass it on to Whitney to give you your update, and we will be having some asks of you, and we will be following up with you. So take it away, Whitney. We don't hear you.
That was also a rookie mistake. I should know better being a millennial using Zoom, but here I am. So thanks for having me. And what I'm going to share with you all today is about the regional health assessment. So I want to start off by talking about and making sure that we all are on the same page with what the regional health assessment is. And so I'm going to start there. The regional health assessment is a picture of our community. And the picture describes various factors around our community. And those could be factors around health, social factors, the built environment, education, economic. And so think of this picture as what our community, the Central Oregon region, looks like at a point in time. Another way to put it is that it's a collection of information that describes the picture. And this process is done every 5 years in our region. The regional health assessment is not made up out of thin air. We have to follow a guiding framework. And so what you see here are components to that guiding framework. And so at the top, you see the MAP framework that stands for Mobilizing for Action Through Planning and Partnerships. And this is our guiding framework on how we put everything together. It's a community-driven strategic planning tool for improving the performance of local public health systems and health systems and creating healthy communities. And it was developed by the National Association of County and City Health Officials and the CDC. And the Oregon Health Authority says that, you know, you should consider using this framework. And so we've taken them up on that. We also have IRS requirements, and that is because St. Charles Health System also has a requirement to be part of this process. And so they're in charge of making sure we do all the things that IRS says we need to do. And then we also have public health accreditation requirements. And so all 3 of our public health departments in the region are also involved in the development of the regional health assessment. And they're the ones making sure we're following all of our public health accreditation things that we must do. And then you see there outlined in blue, the CCO legislative requirements. And so the Central Oregon Health Council, we are ensuring that all of the CCO legislative requirements are fulfilled during this development process. And so all of us entities come together and we utilize this guiding framework. And so what that means is that utilizing that guiding framework, knowing that it's a picture of our community, I always like to start with the end in mind. So that means we're driving towards the next regional health assessment, which will be in 2024 for the publishing date. A vision that is a final document that reflects being a community-driven process that's comprehensive, equity-focused, approachable, easy to use, and meets all of the requirements that you saw in that previous slide around our guiding framework. What this means is that our vision is for the 2024 regional health assessment to look different from the 2019 regional health assessment. And that's because we now have the Central Oregon Health Data website that shows most of the necessary data that we need in real time. And so our final product this time around will be shorter. It's going to be a document that we're going to utilize infographics and social math. And so on the screen there, you see an example of what that might look like in the final product. And if readers want to know more data on a certain topic, we're going to be linking directly back to the corresponding spot on the Central Oregon Health Data website. And so we really are envisioning spotlighting and highlighting various data and information that we gather through this process. So let's think about what the 2019 regional health assessment looked like in order to go forward and dive deeper into the 2024 regional health assessment. So I want to acknowledge, I do see that things in the chat are coming through. I am running a spaceship behind the scenes and I cannot read the chat right now. And so I will address questions after I'm done. So with that being said, the 2019 RAW, just to jog our memories, is what you see on the screen here is kind of like a map of how the 2019 regional health assessment was created and what it's made of. And so on the left side, you see the required content that we must have according to the guiding framework I described earlier. And then in the middle, the source is where you see that data, where we're getting it. And then what you see is what it all culminated into is the 2019 regional health assessment. So the secondary data, think existing databases like the Public Health Assessment Tool, the Oregon Student Wellness Survey, the Behavioral Risk Factor Surveillance System, emergency room usage data. This is data we can find from other sources. And the primary data that we utilized, or data that we collected ourselves in the 2019 regional health assessment process, was through listening sessions. And so that's what the 2019 regional health assessment looks like. Now for the 2024 regional health assessment, it looks slightly different. And so let's remember that the regional health assessment is a package of information. And so, yes, we have that secondary data that will still be represented. And what we will be doing is leaning on an advisory committee that I'll describe in a few slides that will help us prioritize which data to pull, because we don't have to pull all the data anymore. We have the health data website. What you see that's new here is that those orange boxes, and that's the community health survey. This is the first time we're collecting primary data through this method for the regional health assessment process for this region. So primary data, again, meaning information that we're collecting that you cannot get from another database. And what we'll be utilizing is lots of ways to promote this survey, and I'll talk about how you can help promote this survey in a little bit. And then the third component you see is the listening sessions. And so we're operationalizing this time around by being another way for us to collect primary data that goes deeper than the survey. So it's going to augment what our survey is asking. And what we're doing this time around is we're hiring facilitators from community-based organizations. We'll train them and support them in facilitating these sessions, because in the 2019 version, it was Central Oregon Health Council staff that facilitated these sessions. And the reason why we decided to make this change this time around is because for better or for worse, we want to have it be more aligned with our community outreach strategy that we have going forward with Central Oregon Health Council. And so we're not here to research our community, but rather we're here to learn with our community. And so we're going to need to do that with multiple methods of information collection, because how we ask and what we ask does need to look different based on who we're asking, right? And so we're building that into the process. So I want to acknowledge that staff that have come before me have come and talk to you about the regional health assessment, and that this process of developing the 2024 regional health assessment, it started in 2022. And so it was with a mix of previous and current staff from Deschutes County Health Services, Central Oregon Health Council, and St. Charles Health Services. So I do want to recap what happened in 2022 so that we can see how it all fits together in the year 2023. So in 2022, St. Charles, Deschutes County Health Services, and Central Oregon Health Council worked with an outside agency to develop the first version of the Community Health Survey. And the goal was to make it a continuous survey in order for St. Charles Health System to replace their phone survey for their community health needs assessment. And the survey was launched in June of 2022. And there was an outreach plan. And that outreach plan was only partially executed due to staff changes. And we've had some learning since the launch of the survey and the launch of developing the 2024 regional health assessment that affects the entirety of our development approach. And so we kind of put those learnings and enhancements into 3 buckets. So the first learning and enhancement that we made is with our overall approach. So in developing the 2024 regional health assessment, we are ensuring that it's connected to the overall Central Oregon Health Council community engagement strategy, which Miguel will be sharing with y'all in a future meeting. What we're doing is we're leveraging every single component of the regional health assessment process for community engagement. We're not going to use a top-down approach by swooping in, asking people that we've never met to answer our questions, and then not engage with them for another 5 years. Instead, we are building this process where we can develop and deepen relationships across the entire region. And the survey component, so right, the regional health assessment is made up of a lot of different parts. The survey is one of them. We could have kept the survey the same as it was when it was developed in 2022. And let me be very clear, previous staff that began the community health survey for the regional health assessment, they were trailblazers in this project component. When new staff from both Central Oregon Health Council and Deschutes County Health Services came on, we received some overwhelming feedback from the community. Some of that included that there wasn't enough participation from a diverse and regional perspective in developing the survey and making that tool. That the survey itself needed a lot of plain language modifications. The reading level for that tool was too advanced for the general public, and the survey was too long. And our survey results were in line with the feedback that we received. And so from the first version of the survey, we got about 700 responses, and the responses are primarily from white women who lived in Bend, own a home, and are over the age of 50. And we know that's not reflective of our entire Central Oregon region. And so with the feedback we received on the survey's first iteration, we took the opportunity to make enhancements of the survey with its second iteration to be responsive to community and making it shorter and using more plain language. And we've enhanced the survey to only ask for information we cannot get from secondary data. And please know, we're still going to be utilizing the data that we got from the first version of the survey, and we'll be incorporating it in some way, fashion for the 2024 regional health assessment. And then the third enhancement that we made is with the listening sessions bucket. And so, like I said in the previous slide, this time around, we are recruiting, training, and paying community leaders to facilitate these sessions. Last time, all of those sessions were facilitated by staff members. So this time, staff will be supporting community leaders and community-based organizations, but we ourselves are not facilitating the sessions. And we'll be contracting with local community-based organizations in this process as another way to develop and deepen our relationships and honor all of the labor that goes into these listening sessions. We should be paying people because it's really time intensive. And so now that I've talked about like the structure and what this thing is made of, I want to quickly highlight who's involved. So there are two levels of involvement in making this thing. We have our core development team, and that is made up of representatives from Deschutes County Health Services, Crook County Public Health, Jefferson County Public Health, St. Charles Health System, and COHC staff. So myself and Miguel Angel Herrada. And then the steering committee is co-coordinated between Deschutes County Health Services and the Central Oregon Health Council. And the steering committee advises the RAW core development team in order to create a regional health assessment that is aligned with the values and the vision that I shared in a previous slide. And the representatives on the steering committee are from the entire region. We just had our first kickoff meeting last Friday, and I was told that I had a pretty good playlist, so I'm going to keep that going. And that group is to ensure that we're that they're advising the Raw Core Development team to make the regional health assessment aligned with our guiding principles and values. And so I'm going to give you a snapshot on how this thing will become a product. So how we're going to make this thing and when we're going to make it. So what you can see is the different components of the project to make the regional health assessment. And what I want to drive home on this slide is that you see that we have a plan of having the 2024 regional health assessment published by the end of January of 2024, so that we can have the majority of the year of 2024 to develop the 2025 regional health improvement plan. So we want to give ourselves as much time as possible to do that process and do it well. So I've shared with you, what is the regional health assessment? What is the recipe of this health assessment? Who's helping make this thing? And now I want to transition to how you can help. So we definitely need your help to make this thing successful. So up here are some suggestions on how you could take us up on this idea of getting involved in helping. The community health survey has been relaunched as of March 1st. And so we do need your help in increasing the response rate and making it representative of Central Oregon region. And so by the end of March, we will have a promotional toolkit that organizations can utilize. It will have social media messages, social media graphics. It'll have images and posters and graphics for waiting rooms, whether it's TV monitors or rack cards, just various ways that you can utilize promoting the regional health assessment in your entire organization. And when it is available, you'll be getting a really exciting email from Miguel and I. We also need to be conducting listening sessions. And so if your organization is willing to partner with us to host one with the folks that you serve in the Central Oregon region, we would love to partner with you. And so if that is something you would like to do or that you'd like to learn more about, please put your name in the chat and Miguel will take note of that and then we will follow up with you. The last thing I want to share is specifically for the Central Oregon Health Council Board of Directors. So we want to make things interesting this time around. And so we propose a little friendly competition. So we have the ability to create a unique survey link and QR code that can be tied to an organization or a person. And we can track the number of survey submissions that we get through that link or code. And that's the only thing we would gather. We can't have the survey results from that code, but we can know how many surveys came in as a result of that code. And we propose a little friendly competition. Any board member that wants to participate, they can participate. You don't have to, but the board member with the most submissions by September 30th wins dinner from your very own Central Health Council, Central Oregon Health Council staff. So if you're in for a little friendly competition, just type in "I'm in the chat, and then Miguel will make note of that and we'll follow up with you and get you your very own unique codes along with the promotional toolkit.
And I just want to add to that, Whitney, I will be cooking Filipino food for this prize. So all from organic food sources, and you may have some live music available also.
Yeah, we do have a musician on staff as well. So I realize I did a lot of talking and I probably did it real fast. But with that, I know I have about 2 minutes for questions, and please know, like, Miguel and I are happy to meet with anybody over coffee to talk about the regional health assessment and dive in deeper. But we just wanted to give you this update.
Thank you, Whitney. Are there any questions for Whitney or health assessment? If none, Whitney, I thank you for a great presentation. I've been waiting for this presentation for a long time. I've been a real fan of the community health assessment process, and it sounds like you've got a great plan going forward. I did have one question. When we develop the assessment, will it share data just from people that are Medicaid qualified? or on the Oregon Health Plan, or will it include the entire age range in the counties?
That's a great question, Linda. So one of the requirements for the regional health assessment for CCO legislation is that we include the entire population, not just the Medicaid population. And so through the regional health assessment, we're focusing on anybody and everybody that lives in Central Oregon.
Great, thank you. Any other questions? Thank you again, and we'll move on to the next document when you're completed with your work. Whitney, Carmen, would you like to introduce Miguel?
Sure. So the next piece here is our regional health improvement plan. And I will be passing this over to Gwen. And, you know, just to recap on a lot of what Whitney says is that when this regional health assessment piece is completed, this is what informs the regional health improvement plan. The piece that Gwen is about to share with you is the regional health improvement plan that we are currently in. Take it away, Gwen.
Thanks, Kelly. I'll go ahead and have you share screen, share slides. Thank you. So this is the Regional Health Improvement Plan. This is the result of what happened, the assessment that happened back in 2019 that was referenced in the previous presentation. And right now it's running, we're in the cycle of 2020 to December of 2024. And so we periodically give updates. We gave an update in the meeting packet back in October, but it's been a while since we've had a chance to look at it together. So excited to bring some updates to you. The next slide. So each the work groups have been entrusted through the JMA to have funds to invest back into the community. There are a number of work groups, and there are 6 work groups, and each work group has $2 million to invest into the community around their priority areas that have been defined by the community through the regional health assessment over this 4-year plan. On the back end of it, the funds come in periodically and are not, sitting waiting for available, but we have pledged to the community groups that this 12 million is available to them through the course of the cycle. So as you can see, we're in the middle of not quite the middle of 2023. And so far, the work groups have invested about 60% of their funds for this 5-year cycle. The other 41% have been allocated. They have plans in progress for where those are going to go. Next. You can see a little bit more detailed breakdown by work group. On the left side is the dollar amount available allocated to the work groups for their 5-year cycle. The orange indicates the funds that each work group has invested so far in projects that are live. Many of these projects are multi-year projects. And then in the blue is the allocated fund. So that's the residual of the 2 million that they've been pledged by you all to put into the community. And so you can just see the breakdown by work group as outlined at the bottom of the table. Next. If you want even more detail, here breaks down to a little bit more numbers by work group, still that five-year cycle. And on the right side, you can see the funds that they have allocated, that they have them all earmarked, and some of the focus areas. And we'll look over that work group by work group here in just a moment. Next. So we'll start with the behavioral health, increased access and coordination work group. Each of these slides has a similar format. So you can see on the left under the orange, what the work group has currently done, how they've invested their funds. On the right, you'll see highlights from those investments. Some of those investments are a 1-year investment. Many of those investments are 3-year investments. Some of those investments have been made 2 years ago and some earlier this year. So we continue to get progress notes and updates from those investments as we go. So we share those on the right. And in the middle, it's the current focus of what the work group is currently working on and focusing on. So in behavioral health, you can see their work has been around their 3 future state measures, with investments around improving quality measures and communication between specialty providers and primary care, They've also funded work to help build the workforce that included supporting a psychiatric residency program in Central Oregon and training and supervision and financial support to behavioral health interns. There's a quote on the right from a training program for interns that helps empower the interns, provide them the support so they can see clients quicker and with better quality to increase the numbers of providers in our region. And then their current focus is around advocacy and continued work on the workforce development. Next. Next work group is our stable housing and supports work group. They continue to move forward with building alignment and communication between the multiple housing and homelessness organizations that are working on getting folks out of houselessness and addressing gaps in services. On the right is a highlight of the work done through the Homeless Leadership Coalition grant called Increase Continuum of Capacity in the Effort to End Homelessness. And their current focus is around advocacy, outreach, and education, and then identifying gaps and opportunities for coordination across groups and sectors. Next, we have substance and alcohol misuse. They've been working on an assessment to identify factors that contribute to binge drinking in Central Oregon. This project has provided data-driven recommendations to help strategize interventions aimed at the root causes and local conditions of substance use. They funded a two-part project to sustain peer support services in Central Oregon. And the third area is assessing the community's interest and readiness to implement healthy retail locations. And this project will lay the groundwork for future healthy retail projects by identifying interested businesses and gathering community members' input and desires. And the information they gain will help determine whether to pursue healthy retail further and how to invest strategically. On the far right is a quote from the New Priorities grant, an organization who received a peer support sustainability grant, showing the impact of the funds in increasing the ability of their peers to engage clients into treatment and support their recovery. And then right now they're working on exploring the drink campaign, exploring the Rethink the Drink campaign, youth engagement and vaping prevention, and overdose prevention around with naloxone education, awareness, and access. They currently have a request for proposal launched for the engaging youth in vaping prevention, and they are developing a grant opportunity for increasing education, access, and awareness of naloxone. Next. Our physical health work group has been supporting improved regional coordination of prevention and reduction of sexually transmitted illnesses and program supports for youth physical activity and fruit and veggie consumption. On the right, you can see a quote from one of these projects, looking at how the STI prevention coordination program is set to improve and reduce STI and HIV illnesses throughout the region, specifically with our priority populations of young adults and youth. Current focuses on physical health work group is partnering with substance and alcohol misuse work group around the healthy retail work. And they're diving into oral health needs and that future state measure around improving oral health services and access to services. Next. Our upstream prevention work group has launched a media campaign to promote intended pregnancies, which is one of their future state measures. They're also supporting regional work in improving the childhood immunization rate, developing a community level measure of belonging, and supporting existing programs for early learning and reading development. The highlight that you see on the right is a clip from the media campaign that went live earlier this month called the Ask Anything campaign that supports planned pregnancy. And right now they're currently actively exploring and having conversations around a multi-pronged approach to support kindergarten readiness and letter name recognition with our kiddos who have traditionally been underserved. And finally, our last work group, next slide, please, is our Address Poverty and Enhance Self-Sufficiency work group. They have, on the left, you can see they've funded programs to increase high school graduation among economically disadvantaged youth. They have funded programs to decrease food insecurity in rural areas. And they're conducting the ALICE listening sessions for those living at the asset limited, income constrained, and employed threshold. The information coming from these listening sessions are leading future work that you'll see in our current focus in just a minute. A highlight from this, what they've done, you can see on the right, around the work group's work in decreasing food insecurity in rural areas. And this quote is from the High Desert Food and Farm Alliance's Fresh Harvest Kit program. So the current focus, the work group has just received the final report from those ALICE listening sessions. There was 11 sessions in total, 4 in Spanish, 92 participants. And this month, they're going to be using that information to start the conversation around investments. They'll be releasing the request for proposal, grant opportunity has just been released to develop a metric for developing a metric to evaluate food insecurity around older adults. Lots of exciting things happening across and in these work groups. Some of the projects are well underway, and we're getting year 1 and progress notes, and other projects and work has just started in the last year. And so they're getting up and running. It's pretty exciting stuff. Next slide. And we wanted to finally share with you some of the themes that we're seeing across work groups. The partners are work group partners. That's some of you and many of your colleagues throughout the community have been speaking to the intersectionality and the connectedness of their priority areas and the future state measures. They're really demonstrating readiness and energy and desire to take action to collaborate across work groups. You can see what these look like in the middle. Behavioral health, substance and alcohol misuse, and housing have demonstrated willingness and interest to partner with each other, recognizing that behavioral health lives not just in the behavioral health work group, but across many areas. And then some groups are currently partnering in some specific activities. On the left, you can see that the physical health and substance and alcohol misuse work groups are partnering around a project involving healthy retail, as I mentioned earlier. And on the right, you can see that the Addressing Poverty and Stable Housing are partnering around the ALICE listening sessions. So this brings us into a new chapter of work group partnership and collaboration that we're excited to support. Next slide. Any questions? If anything comes up later, we're happy to answer them offline. Thank you.
Hey, Gwen. Oh,
Go ahead, Brad.
I was just curious about the Cody work group. I know it's not the same as the ones you just presented about, but do you have any updates on the diversity, equity, inclusion work group?
Sure. I think we have a formal update planned in the near future. So the Cody work group is actually a Cody committee because it underlies the equity level and health equity level work that we want to be doing across the organization that will outlast and live throughout future cycles. They have been meeting regularly for about 3.5 years now, and are diving in to better understanding their identity as a DEI group within the constructs of the Central Oregon Health Council. They're doing a review of their charter and their role and influence, looking at the work that they've already done and how they've influenced the organization through stimulating the commitment to DEI statement, learning sessions, the collection of real D data, and reporting out on who participates in the work groups. They've also stimulated work around doing a health equity review of the investments that the work groups have made. We're currently collecting that data from current investments, and we'll be sharing that out in the next few months. So they're kind of doing a review and identifying where are we, who are we, what do we want to ask, and how do we want to function as a DEI committee within the Health Council. So they're in an exciting spot, kind of a refreshing and rebirthing place, as they've been doing this in one aspect, in some aspects, and wanting to continue that and grow that.
I just wanted to acknowledge the whole team as they continue to develop these RIP work groups. Just as a reminder, we have about 200 participants collectively that feeds into this work, which is really community-led, and the facilitation that happens along with it. So thank you, team, for making these work groups really evolve. Thank you.
Thank you, Carmen and Gwen, for it's a huge project, and I know that it's really guided our work in the last 4 years. And I'm excited to see how it will direct the work of the council for the non-CCO part of our work, and sort of bringing those together with the CCO part of our work as well. So thank you all for the effort and the update. Let's move on to the next agenda item, which is the Governance Committee report, and I will try to zip through this pretty quickly. There are 3 documents that we'll be discussing today. Governance Committee met about 3 weeks ago, and the first document, which was in your packet, is the board job description. We've been working on it quite a while. Those of you who've been around for a while may remember that we did the board policy book pre-COVID, and have been working through since COVID, making sure that the document is updated, that we have policies and procedures in place, and the board job description is the next piece of that work. It's consistent with the bylaws and the policy manual, and it really provides a clarity about what each of our individual roles are and responsibility when we come on the council. What is it that we agree to do, and how do we agree to perform? Both individually and board responsibilities. That's the next document. I'll jump to that one in a minute. So this one, the Governance Committee has recommended for approval by the board. And if there's anything else that the Governance Committee would like to add to this policy, or what I've said about it before we take a vote, or if there are questions from the group, please fire away. If there's no questions or comments, could I have a motion to approve the board job description? Motion to approve the board job description?
Yes, so move, Linda, to move the job description.
Thank you, Patty. Second?
I'll second.
Thank you, Justin.
Sure.
All in favor? Say aye.
Aye.
Any opposition? So that document is passed. A piece of that document includes an annual completion of a conflict of interest statement. So in the next month or 2 or sooner, you'll each receive a conflict of interest statement. And Carmen's working on the final model of that. So just expect that coming into the mail. The second item that we discussed is, and a requirement in our bylaws and our policy book, is for the board to do an annual self-evaluation. And that self-evaluation can be done through looking at our own personal performance as board members, or it could be, how does the board operate, and has the board operated in the past year along certain criteria. When the board self-evaluation is done, that then becomes fodder for our board education retreats and the board retreats that we have coming up in June. So we need to get to the board self-evaluation in the month of April, so we can be queued up for the education sessions in June. The Governance Committee talked about it, and we decided that there were some elements, and Carmen, you may need to help me on this, that you'll see every year, whether it's an internal self-evaluation personally about your performance as a board member, or whether it is the performance of the board in the last year. I can't remember which one or two of these will be evaluated every year, but the 4 areas that the board or that the governance committee recommends the self-evaluation include are duties and responsibilities of the board. We'll develop questions that will deal with whether we clearly understand our mission, our true north principles, knowledge and awareness of the board policy manual, as well as the duties and responsibilities of a board member would be in that first section. The second area of focus will have questions pertaining to the strategic plan to gauge how clearly do we understand the strategic plan, its growth, and the outcomes that we expect. The third will be our role in fiduciary oversight. We'll ask questions that focus on our financial stewardship, a clear understanding of our financial statements, and a conceptual understanding of the financial components of the JMA. And then the fourth area will be our engagement and conduct. As a board, we'll be answering questions about the nature of our involvement through attendance in task forces or committees of the board, work groups of the council itself, as well as community involvement and stakeholder introductions. So those are the areas. We're bringing this up to let you know what our thinking is, because we need to jump to this in the next month. We wanted to give the board an opportunity for feedback. If you agree with these metrics, if you have follow-up questions about them, or you think we should be looking at a different metric to measure this year.
Thank you, Linda. And I just wanted to add that the 4 areas are best practices of a lot of board self-evaluations, and they will be quantitative in nature, so we could benchmark our success through the years. And there's another component here, the focus area, indicating that, should we find in our self-evaluation areas where we need to strengthen, then that would be our focus area, which is more of a qualitative piece in the self-evaluation.
Carmen, are there any comments or feedback on this piece? I will assume that silence is consent. Okay, let's move. Yes,
Linda, and I really appreciate the work that's obviously gone into this. So very good work.
Thank you on behalf of the whole committee. Thank you, Rick. Let's go into the last document. And the topic area is the executive director evaluation process. Last month, we brought it up that it was getting close to the time for Carmen's annual review, and sought guidance from the board on a process you'd like to see. It was referred back to governance committee to develop some metrics that would measure it. We talked about the metrics. We talked about the timing of the performance review and the different components. And the governance committee recommends at this point that we have an evaluation tool that will, for this year, the metrics we recommend will include strategy and planning, financial stewardship, program management, and human resources management. Those would be the areas and the metrics that will be developed underneath those. And so before we go forward in the next couple of weeks to develop the actual metrics, we wanted just to make sure that these were the 4 areas that would be the most important for us to include in the performance review this year. This, in addition to the board's evaluation on these criteria, there would also be an executive director's self-performance review, and which gives us a sense of maybe things that are important to the executive director, growth edges that they've done, other things that haven't risen to the surface that the executive director is really proud of doing that would be important for us to know as well. So my question at this point is, does the process we've described sound okay? And then are these the 4 criteria we want to move forward to develop the metrics around? Brad, I saw your hand raised.
Yeah, Linda, I think it's missing community engagement. I don't see that any one of these 4 measures how Carmen engages with the community, which is one of her strengths. So
I can see that possibly entering into program management as one of the key areas we're working on, but definitely will note that. Thank you, Brad.
Thanks, Brad. Dan.
Hey, thanks for the work here. Two things real quick. One of them's kind of small. That one is, it looks like the first two sections are almost kind of a cut and paste from the previous page, like with reference to asking questions about those things as opposed to measuring progress or performance. So it might just be semantics, but it seemed more like a survey than a performance measurement tool. The second area, kind of in keeping with Brad's comment, was CCO partnership. A lot of what the executive director does in relation to the health council's oversight and work with the CCO is work with our teams to help on some really critical deliverables for the OHA. And so for me, that's a big piece of what the executive director does that I'd love to see reflected here.
Great. Thank you, Dan. We'll make sure that's included.
Thank you.
Other thoughts or questions?
Linda, I think I would just want to reiterate both Dan and Brad's comments and strengthen those. I think those are actually two really important roles that don't stand out here, is partnership with Pacific Source and engagement with the community and various community partners. So I think those are vital for the role and the success of the role. So I would not want to see that slid in under program management, but I think it really should be its own category.
Great. Thank you for that feedback, Rick. Other thoughts? If not, I appreciate the feedback. We will take those seriously and make sure that they're included as we roll out the next steps. You will see the modified form of the survey actually coming out for the end of April so that we can assess your thoughts on that. And that will be a confidential process. We'll discuss all of this in executive session. The second part of the executive director evaluation that was in your packet was a one-page policy that you see on the screen. And governance committee, if the council is supportive of this policy, we would ask for action to approve the policy. Policy states basically that our process will be that 4 months prior to the anniversary date, the executive director would provide input in writing to the executive committee on how they feel that they have achieved the annual goals established the prior year and the objectives that were established by the board in the prior year. The executive committee will review with the executive director for clarifications, edits, and concerns. The executive committee would review current salary level of the ED and determine whether a salary increase or decrease or a bonus will be recommended, and then would establish an executive session with the board in October to discuss their findings and their recommendations to the board on salary adjustments, bonuses, those sorts of things. In that executive session, without the executive director, the executive committee would talk with the board about what their assessment is, the data that they've received, and just discuss with the board to make sure that we come to a consensus on what the evaluation should be included and whether the decisions that will flow from that. And then after that discussion, the executive director would join the group. It's still an executive session. This policy ties any bonus or salary changes to the review process. So it will have that would happen once a year annually. And the board would make, after the meeting with the executive director on the anniversary date, the ED would prepare a draft of the goals for next year. And the board in the next month would review those and they would come to agreement about what the goals for the coming year would be. And that the governance committee's role with this will be to make sure that everything happens as it's supposed to. But the real work is done between the executive committee and the board. And of course, the executive director. So thoughts or comments or concerns with that process? As you may remember, we've been struggling prior years with a more loosely structured performance review process, and the board a couple months ago mentioned that they'd like for us to propose a policy to tighten that up.
Hey, Linda,
Yes, Brad?
is number one, is that to be interpreted as a self-review essentially, or like a self-performance
Yes.
review?
Yes.
Okay.
And in this year's review, because there weren't goals established a year ago, but you've just given input on what the goals would be for this year's review. Carmen won't have anything to go from last year. This will be her first annual review. And once that's complete, then we set up the goals for next year. Good. Thank you. Other questions?
Linda, this is sort of a timing question. So the goals would be set, and then if I'm doing math, then we'd be 8 months into the goals when Carmen would provide that overview of how the performance is on those goals.
Yes, roughly speaking.
Okay, so.
Yeah, so it's not a full year. Otherwise, it would be a 15-month review cycle as opposed to an annual.
So is it sort of the expectation that the goals would be achieved? So they would be done by the time that that's submitted to the review committee?
Can you repeat that, please?
So when the review happens on the performance of the goals that were set, 8 months.
The prior year.
Is the expectation those goals would be achieved at that 8-month mark?
Yes, and there would probably be some flexibility in it. Because we know if we establish, and what we could try to do is to, within a month of completing the performance review, the following month, we would have the goals set for the coming year. That would give more time for accomplishment.
Yeah.
But from the first self-assessment to the end, it's still going to take a couple months to work its way through the board.
Great.
Any other thoughts or questions? If not, if people are supportive of this policy, I'd like to see us develop this as a policy of the board in terms of the process we'll use from year after year and where responsibility lies for each step of it. And if I could ask for a motion to approve.
This is Gary Allen. I'll move to approve.
Thank you, Gary. Is there a second?
I'll second. This is Dan.
Thank you, Dan. All in favor? Any opposed? Good. Thank you very much. That one's passed and the governance report is complete. Now we move on to the Pain Standards Task Force report. That would be Gary.
That would be me, yes. And I was asked to tell the story of the Pain Standards Task Force, and it's a longer story than I'm going to be able to do because it's been in existence for 8 years, accomplished a lot, as you can see in the packet. So this will be a Cliff Notes version in 10 minutes and I think about 4 or 5 slides. And I also want to mention that there's an article that has been written by staff on the accomplishments of the Pain Standards Task Force, and that will be published, as I understand it, in the Central Oregon Health Council newsletter, which is still pending, but that will fill in some of the blanks that I don't cover today. And I also want to mention that, or thank Camille for preparing the slide deck, so I have something to talk to. And for all of the staff through the 8 years and counting existence of the Pain Standard Task Force that have contributed and supported our work, and that's ranged from Kelly, who has been intimately involved, Rebecca, Barry, Kelsey, Renee, and more and more and more. I can't name them all. And I was asked to do this because I am the former co-chair of the Pain Standards Task Force, but I'm a poor substitute for Kim Swanson, Dr. Kim Swanson, who was the chair, a very charismatic chair for throughout the existence of the Pain Standards Task Force before she stepped down just at the end of last year. We certainly couldn't have gotten anything done without her dedicated leadership. It was a passion for her, as it was for all of the volunteers on the task force. It was formed in 2015, and it was formed as a response to the alarming rise in opioid-related deaths and the stresses on the healthcare system, providers, as well as stress on the community at large. And we wanted to develop strategies to address those concerns. But the intent was also, and hence the name Pain Standards Task Force rather than Opioid Reduction Task Force or something like that. But the intent was also to transform the healthcare system and to call attention that there are alternative evidence-based strategies for addressing chronic pain, non-cancer chronic pain and persistent pain that are effective. Next slide, please. We collaborated from the beginning on a 7-point strategy that was going to guide us for the duration of our work. This was our North Star. It really began around adoption of safe prescribing practices. And this was early on in the process, even before the CDC had developed chronic pain guidelines. We wanted to sponsor a series of trainings that would help get the information out there, both to providers and to patients. We early on endorsed and promoted the prescription drug monitoring program enrollment by providers, and then monitored utilization by providers in Central Oregon. We were early adopters and actually participated in the development for Oregon of chronic pain prescribing guidelines and also the acute pain prescribing guidelines. With the support of Pacific Source and their resources, we were able to identify providers that had a history of risky prescribing practices. And through a dashboard, we're able to show them where they stood in relationship to their peers, which influenced, in most cases, their movement to more safe prescribing practices. Next slide, please. In the next two slides, I'll just finish up with the accomplishments, and this is just a brief few. I could go on, and I'm not going to read them all. You can read them as well as I can. I will just highlight a couple. I think one of the most significant accomplishments is the comprehensive website that was developed and is widely utilized by providers and by patients because it wasn't just limited, information is not just limited to providers. This was most recently in the last couple of years revised, and this was one of the crowning achievements of Kelsey Seymour as she was exiting the Central Oregon Health Council. And if you haven't been there, I would invite you to take a look at it and look at all the resources that are available through that. Other efforts of the organization or the task force was to raise public awareness for the region through media campaigns, press releases, interviews, and a variety of other events that were really focused on patients and providers to make them again aware that of the opioid epidemic and the overuse of opioids and how even short-term use for at-risk individuals to treat acute pain could lead to more long-term use of opioids as acute pain went on into chronic pain. And Kim in particular was very involved in the development of participation in statewide task forces, and she personally consulted with legislators, Representative Walden and Senator Wyden, as they were developing policies for combating the opioid substance use epidemic. Next slide, please. And finally, one of the other major things that we did that was well received by the community was a series of events that were not just for providers, but actually were for patients as well. And to include some that were multi-day, that covered a variety of topics that were really focused on differing disciplines of the healthcare community and different individuals that were suffering from chronic pain, and resources that were available to assist them in managing that. One of the most popular, based on feedback, programs that we sponsored was the naloxone grant program. That was where we made Narcan available to the community, to stakeholders, to first responders, to substance use disorder facilities. In many cases, we were able to supplement what they had, or in some cases, we were the only source of Narcan for them. Received great feedback, particularly for sheriffs and police departments, as to the number of lives that were saved as a result of this program. And then finally, through the support of Rick and his behavioral health colleagues, we were instrumental in embedding substance use disorder counselors in emergency departments so that they were readily available for members that presented with substance abuse problems. And I would acknowledge also that there's other members on the board, Divya, Jeff, and Rick, that have been volunteering in the organization since its inception. And they might want to add a little color. They're welcome to do that. Also, that we are going through a transition, so this is a very timely presentation. We previously met monthly at Pacific Source in Bend and shared coffee and breakfast bagels, bagel sandwiches. We continued that until COVID, and then we were driven into our homes and onto Zoom. And as a result of COVID, our numbers dwindled because of a number of members that started having to focus on other healthcare priorities, obviously. So we're actively recruiting as we transition into the chronic pain or substance abuse group that's in Prineville under Katie Plum's leadership. And she or Stacy Shaw may contact a provider or two in your organization seeking them as volunteers for involvement in the Pain Standards Task Force as we continue our work going forward. So with that, any questions that either myself or other volunteers on the task force can answer?
Hey, Linda, this is Mike Shercliffe. Can I make a comment?
Yes, please, Mike.
I have to say, I have to really appreciate Gary and his work for doing this, because he's been, I mean, actually from the beginning, even back in the day when, like he talks about. But one of the things I have to say is one of the things this did is one of the measurements that were measured by is patient unhappiness. And one of the things that people who were seeking drugs were doing were using the fact that they couldn't get their prescriptions as a tool to file unhappiness, which were unwarranted, because the providers were not writing prescriptions they knew that weren't warranted. And one of the things this did was shine a light on that activity, and it helped the providers and the pressure they receive from patients and others who are seeking drugs in an inappropriate way. And so I have to really have to thank this committee and this whole effort to help shine a light on what was really going on in the community that put the providers in a really awkward place.
Thank you, Mike.
Thanks, Mike. And to that, I will add that in fact, the dashboards and the work of Pacific Source, and by the way, some of this work went on in other CCOs as well, as being able to identify prescribing practices of providers. And I know from my own personal experience, it actually sometimes came as a shock to them when they saw their prescribing practices as compared to their peers. And as Mike mentioned, just shining light on that was oftentimes enough to change their prescribing practices. So it's been, there's a lot of successes, a lot of accomplishments of this group.
Any other thoughts? Gary, I want to acknowledge you and the other Divya and the other people that have been quietly working on this behind the scenes, not taking a lot of credit, not taking a lot of airspace, but doing really an example of work that is the council when it's at its best, where we come together, focused on the patient, focused on a problem, and we work collaboratively together to see what each of us can do, not seeking glory, but just seeking to make a difference. And you've done that with this team, the whole Pain Standards Task Force. And when I'm out in the community and I'm asked, well, what does the council do? That's the Pain Standards Task Force work around opioid addiction is one finite, concrete example that I can get that everybody understands. So thank you all for your service, and thanks for the example that you've set for us going forward.
Thank you, Linda.
Next on the agenda is the metrics. Tricia.
Hello, Health Council Board of Directors. Thank you for the ability to do some rework in return with some performance metrics. I just want to give a little bit of backstory as we lean into this. The 8 metrics that are being presented are the same as the metrics that we covered at the last meeting. These metrics, again, were created in consultation with the Best Practices Health Council Committee and Pacific Source. So that's the executive directors and the chair of the of the board of directors. We meet quarterly in a best practices forum, and it was in one of those forums where these 8 metrics were lifted up. And again, as a reminder, these are across all 4 Pacific Source CCO metrics. So reminder in that space. Also just to help level set, last meeting, the board had requested a few things, a new format and some additional deeper dive into some of the information that was provided. In order to achieve that, a subcommittee group was formed. This subcommittee group met for a very robust hour, and that was followed by several also very robust emails to get to a position of a new presentation today. So I want to thank Linda, Rick, Justin, and Carmen for your work on that subgroup. Leslie was there, as well as 2 additional subject matter experts internally and myself. So let's talk a little bit about what this new document looks like. So on the guidance that was provided last time, we reformatted the metrics so that it was we hope this is a clearer way to both identify one of the 8 metrics, to clearly identify the 2022 performance, the target for 2023. Also, how are these being measured? And or language you heard sometimes is what's the numerator and what's the denominator? And then lastly, is a strategy to achieve those goals and or a performance improvement plan. And additionally, at the bottom of this massive Excel document, there's a reason why I'm waiting to display this so that I can keep you with me for a few minutes. There are reference documents that we're hopeful that can help both inform the board going forward and also aid in education, which seemed that there was some requests along that space. And then there's just a little line at the end of the strategy. And when I thought about this work, I think each time we present, and Tammy so mindfully, and Linda, I'm guessing in her absence, often says, what can the board of directors do in this place? So I added a line there so that the board could better understand in what places this work is being done. In all but one place, these are held in Central Oregon Health Council RIP work groups, in advisory councils, in provider engagement panels, in newly formed operations councils, in quality improvement measure work groups. So there are many places where one of these metrics is the entire focus of a group. And if it's not the entire focus of that group, it ends up like in the provider engagement panel being part of the focus of the work they do in that space. So I added that at the end so that you can hopefully then when we get to that place where we present something, and perhaps the way we will track this is the same. It will be not perhaps, it'll be the same. Perhaps is the next part. So it'll be tracked in a green, we're rocking. Yellow, there's a little caution and we should lean in and consider this work a little bit more. And red is that we don't project to be on target unless there's some significant intervention. As you can recall, last year there were no red in this space. There were some yellow. That did spark some conversation going forward. So the perhaps part, I have completely lost. So whatever I was going to be brilliant about there, we'll have to just wait. So I would like to now display this document. And again, just caution, we are not going to go through the whole document today. The subcommittee group did approve. And then I just want to be really clear, we didn't change any of the metrics. They are all the same from the initial presentation, but clarity was provided. Instead of me verbally going through what are the targets and what are the, how do we measure the outcomes and what is our strategy, it is all captured in ready or not, here we go, in this large document. Tell me you can see an Excel spreadsheet. Okay, let me put this in my front screen. Oh no. So okay, it's not going to. You'll get a little profile view of me then. Sorry about that if I was dragging you around with me. So I just want to do a quick overview before we dive into details again. So, and I will expand this as we look at a single metric or two. So broken down, the 8 metrics follow the left column. The performance, as you see me highlighting, hopefully with my mouse, followed directly by the target. So hopefully very easy to identify what was our performance last year, what is our target for next year, what are we measuring? What does it mean that we are seeking to have 11 out of 15 metrics identified? And again, just call out to Paul Andrews that that does equal 100% in OHA math. And then over here also new, and again, a lot of this was verbally discussed, but what are our strategies or our performance improvement plan, also called a PIP, to achieve these goals? Now I'm going to take us, so there, that follows each of the metrics as we scroll down. But wait, there's more. Each one of the metrics has a page below where we can do a deeper dive. We could say, what are the 15 metrics? Well, there they are. What do we mean by mental health service? And what are the kind of interventions being done in this work? What is value-based payment? And what does land payment categories mean? Some of these pages also contain live links. So if you want to do a deeper dive even, you can go back to OHA websites and do that as well. ED utilization, and this was part of a very robust topic. And this is the one topic that I would like to revisit for today. And we do have one decision to make here as a group. So we say, what is PCH? Well, it's patient-centered primary care homes. And what is that? And again, a live link in that space. How is our work here governed through the contractual agreement called the Joint Management Agreement? And lastly, I hope this is helpful. You know, not everybody, like Carmen and Leslie and Dan and myself and you know, are as steeped in this CCO work and have a great glossary definitions, and these words can be used often in acronyms. So I tried to pull out when that's the case, but to provide a resource here where you can reference back and say, I wonder exactly, what do we mean when we say milliman? What is that? And we can look back here and reference that. So I'm going to go back to the performance metrics, but I'd like to just pause for a moment if anyone has any questions on how we got to this place.
Tricia, I just wanted to comment that I love all of the definitions and supporting documents.
Thank you. I'm excited to say that this is now the format that will be used across all CCOs. So when one board lifts us up, it lifts us all up. So thank you so much for your work in this space. So in lieu of going through these individually, what I want to provide is just a reminder that our intention here is that this is going to be an ongoing conversation, that I will report out our status on each of these metrics quarterly and allow for conversation time on individual metrics that we may have some concerns about. And then decide, where's the best place? Should the provider engagement panel chair come and address how they're talking about ED utilization in that space? Maybe QIM work groups come and talk about the 2 QIMs that they may have concerns about out of the 11 QIMs we are trying to meet. Of course, we're trying to meet all 15, but 11 will get us to 100% payout. How are we doing finance with redetermination coming? Are we going to continue to be in our positive net income? So where the board has already requested 2 deeper dives in this space is one in terms of value-based payments. So our VBP, as you'll hear referenced, contracts. This is an incredibly complex and dynamic space. And that might be the understatement of the century. And Peter McGarry, who leads that work for PacificSource, is our VP of contracting, and he will come and do a presentation. And he did that last year as well. And that will really talk us through what are we talking about with this LAM framework, and what does it mean, and how do we meet our contractual obligations for value-based payments, and what's the why? Why do we do this work? The other place the board has already leaned in and made a deeper dive request is with grievance and appeals specifically. So we will have Jessica Waltman, who's the Director of Grievance and Appeals for PacificSource, come and present specifically on that data. Like how many people have grievance and appeals throughout each quarter, yearly? What kind of interventions are we? And that'll speak to our last. So I'm going to bring this up on the screen. What are our strategies for achieving these goals in both non-emergent medical transportation and oral health? And what work is being done in the community? And if we've launched some interventions, are we seeing any changes in our concerns, our complaints as a result of these interventions? So I think there's already a couple places where we will really have an opportunity to have the experts in this space have a conversation. And again, continue tracking throughout the year. I would like to pause just for a moment, and then I would like to have a more robust conversation. Maybe I can make this a little bigger about the outpatient emergency department utilization. Does anyone have anything? Oh, no, don't change the color of the font, my bad. Does anyone have any comments or questions before we move on to the specific ED utilization?
Tricia, I'd just like to comment and acknowledge you that with all of the data and each person on this call with different levels of awareness of the data and where the source comes from and who's involved and who's overseeing and who's engaged in the conversations, you've done a masterful job of pulling it together into one location in a way that, at least from my limited involvement, seems pretty easy to digest. So thank you. It's a constantly moving target.
Well, Linda, that's the 3rd time I've had goosebumps this meeting. So thank you so much for that. Yeah, I think that there are some great strengths in having new people at the table. So as Carmen and I work together to digest this information together, we get the opportunity to, we're pretty new at this too. What would we need and how can we share this information better? And so we try to use that new lens as a strength too. And Linda, of course, thank you so much for leaning in the subgroup. That was a really meaningful place. to help shape this work. So I'd like to, as we talk a little bit about outpatient emergency department utilization, some of the conversation that we had in the subgroup meeting is captured here and some is not. We talked about maintaining in the well-managed group. I do want to pull up this graph and share that our internal data analyst, Carly Hedrick, pulled the data back to 2018 upon Justin's request so that we could look at 5 years of data here, which is tremendously helpful. Carly also provided additional data that both Justin and Rick Trelevin had some additional calculations and feedback. And at this time, I'd love to offer Justin and Rick some space to bring the board up to date to what we discussed in the subgroup and subsequent emails.
Sure. And Tricia, if you have the email I sent back to you, feel free to display it, because I think the graph I put in there really highlights the information you all sent. In essence, if you remember at the meeting, the conversation was really clear. It was, there hasn't been a real big reduction in emergency room utilization. There's just been so many more young, healthy members that have come on that you know, there hasn't really been a resource allocation issue. And so what we wanted to do was prove out that hypothesis. And if you remember during our last meeting, Dan and I even went back and forth. Well, if they were young and healthier, the RAF score would have went down. And if they were young and healthier, then you'd have more members, but you wouldn't have the same level of utilization. And if it's just a function of adding membership that drove down the rate, that would be different. You would see in the raw number of visits, the rate would continue. So meaning if you had 30,000 members and 30,000 visits, well, if you went up to 60,000 and nothing changed the rate, you'd have 60,000 visits. So we went about using corollary metrics. That's what you would try to do when you're trying to prove out a data set on a population base. And Pacific Source delivered that data. And in essence, what it showed was in the 5-year period, the membership grew by about 41%, while ER utilization grew by about 9%. So we had 25,000 total visits to the ER in 2018 off 48,000 members. We had 26,000 ER visits off 70,000 members 5 years later. There is no data set that is as dramatic to show the massive reduction in utilization in the emergency department as that. It's not a metric, it is not, based on that data, it is not just more members. It's that the outpatient network, the behavioral health network, and all the stuff the Health Council has been investing in for 5 years has worked. It has reduced dramatically the rate of utilization in the ER by 455%. So this is now my new favorite data set. And great job, Tricia. And everyone else can chime in as they want to. If you want me to share it, Tricia, I have the email. I can pull it up and share it. But
yeah, I just lost it. I'm so sorry on the fly, balancing 3 screens.
I'll get it.
I can also send it out as part of this Excel document as well.
Yeah, please do. I think you'd be lucky in your whole career if you had a data set that showed something this clearly.
Hey, Justin.
Yep.
I have to push back a little bit. I mean, I think, you know, congratulations, but can you really draw conclusions?
Yeah, you can.
Because what if there's a whole bunch of other reasons people aren't going to the ER, like fear of taking on a huge debt?
Sure, there are a million different things you could say. I'm not applying causality. I'm not saying the cause of this is X, Y, or Z. I'm saying the correlation is so strong that you'd have a very hard time disproving the fact that the utilization is down per members. I'm not saying, I'm correlating this to the 3 different data sets we were presented, you know, in August. A massive reduction in bed utilization and ER utilization, and a massive uptick in outpatient behavioral health and clinic volumes. So I agree with you. I'm not trying to ascribe what the reason is. Certainly some of it could be the pandemic too. All of that being said, if you're allocating resources on the same rate, if you're allocating resources on the same rate, you'd be allocating the same resources for 41% more membership for 27% less utilization. And that's an issue. That's an issue the board or whomever controls the resource portion of the contract really needs to have a conversation about.
So Brad, a couple of things. One is this is only covering CCO members, so they don't take on any debt by going to the ER. Two is what we could track is substantial practice pattern changes from starting in 2018. And really a growing focus on reducing ED utilization. And in fact, we have performance metrics now that are really focused on that Pacific Source has implemented, that focus on engaging people in SUD and mental health services post ED visits. And so, well, perceived debt, the perception of debt would not have changed, right? So we can make an assumption that that has changed, has stayed roughly the same. The perception of debt has stayed the same. So then the first hypothesis was that the pandemic was causing the drop. And I think that was a fair hypothesis. But I would be making a guess, and it's purely a guess, that we would be seeing a signal in the data from 22 of an upward pressure in those numbers if it was purely pandemic driven. So I think what we have, my guess, again, just a guess, looking at the data, is we had practice patterns reinforced by the pandemic that are likely being created this change. And that would be my hypothesis. And I think we have 3 years of data with that. So that's my guess.
Yeah, and I'm sorry, I didn't mention the other really interesting part of the data set was the RAF score in 2018 was 1.16. The RAF score 5 years later is 1.29. So the concept that I left this out, which was a big part of the original hypothesis, was a flood of young, healthy people came in and they just didn't use the ER as much. Well, the disease burden of the population actually went up over the 5-year period, not down. And it was consistently shown every year after 2018 to stay above 1.25. So there's no version in the data set. This isn't my opinion. I'm just telling you in the data set. There's no version of the world where a flood of young, healthy people showed up who just didn't use the ER. In fact, the disease burden in the population got sicker over the 5 years. So that the numbers are the numbers. So I shared my screen. I hope you can see it, but there's a 20% decrease in ER visit utilization per 1,000 patients, a 6% increase in the total risk factor, meaning the sickness of the population. 32% increase in member months, 41% increase in the average membership, and a 9% increase year over year. So I want to say that again, just so everybody gets it. 48,000 members with 25,000 ED visits at a 1.16 RAF score. 5 years later, 70,000 members, 26,000 ED visits with a 6% increased disease burden.
Hey, Linda, this is Mike Shercliffe. Could I make a comment on that?
Yes, please.
And I really like this report because to me, what it shows is how the Health Council and the medical community medical oral health community, behavioral health community, has gone towards a more value-based risk-based system. I can remember back when we used dentistry. I was kind of the whipping child for the ED use, and the hospital wasn't particularly interested in solving that problem until they were at risk. And the moment they got at risk, all of a sudden they want to have conversations about what can you do about it. And I think as the whole system has gone more to value-based, outcome-based, risk-based, that this to me is what's reflected in this report. And I want to concur, I really want to concur with what's being said, because I think it has a lot to do with what the Health Council, the Coordinated Care Organization, the whole legislation set out to do. How do we get a better care at a better cost for more people? And I think that, to me, that's what this shows.
Yeah, I totally agree too. And not, sorry for cutting in, Linda. I just wanted to say too, and this is where the Behavioral Health Network falls in too. A significant portion of the decade-long work that group's been doing is what with social workers and the people in the ER and all of the resources we've deployed there, it works. So, congratulations to that group too. It's the whole network of care that we built, but according to this data set, it is working.
So Tricia and Justin and Rick and everyone who's been participating, and Brad, everyone who's been participating so far in this conversation, I love the robustness of it. I thank you, Tricia, and the Pacific Source staff for listening to our questions, diving deeper. And what I have learned at this advanced age is that data tells a story. The question is, what story does it tell? And what conversation are we in? Are we in a conversation as a group of colleagues to look at and to really seriously look at what does this data mean? And if it's not clear, what additional data do we need to collect? Alternative sources, whatever, to make sure that the story and the interpretation that we're telling is the right one. And if I've learned nothing in the last 3 years with COVID, everything I thought I knew has been turned on its head. So I encourage us to continue the quest and to be clear that our role here as the council is to listen, ask questions, give guidance in the direction, and be clear that we're in the conversation as a group. And there are different conversations to be had. There are contracting conversations, there's program development conversations, and our role as a council is to create a home for all of those and to make sure that we're clear which conversation we're in. So those are just my thoughts. Anyone else?
I just have a question for Tricia. Where will this document be housed so that it will be available to us for reference?
Yeah, I'm happy to. The plan was to send it to the Health Council and that they could then forward this robust Excel document so you can save it on your own, knowing that each quarter there will be an update, and we're still considering how that update could best be presented. So some of this, it may be a different page that resembles the performance metric page, just to mitigate the amount of information in that space. But we would like to give it to you so that you can reference it at any time in this journey.
And I look forward to the next installment of this inquiry around what does the data tell us this week? And what are the things that we haven't considered that could be a root cause that have nothing to do with anything that we're doing? Other thoughts before we move on to the next agenda item?
Yeah, I guess, having put in the time to kind of iron this out, I do wonder, or we don't have to do it today, but I do want to know, how does this get used now? Where does it go? Because we've been operating under the same, kind of consistent, 5-year conversation since I've been here. It's been 5 years, pretty much the same thing. This, nothing really changes. Well, something really big did change. It really did change. And there's a pretty big outcome there. And that means we should be reflecting the way we operate based on what changed. And so I really do want to hear how the data is going to start driving more decisions on, the resource allocation and what we do and where we put our efforts as a group. Because, I fear the very next conversation, we're going to be right back to the same thing of, you know, well, everybody's volume's up. Well, everyone's volume isn't up. That's not the case. The data just definitively showed that. So I always love when we get to this point where there's like something that's plain as day or clear. I always dislike the point where it's just completely back to Groundhog Day the next time we get back together and meet. So I really want to know what we're going to do. We don't have to answer it now, but I do have some expectations that if we're going to pump this much time and effort into getting to root causes, that the information's used to start guiding our actions.
Yeah, and as I've said many times, I hate to publicly agree with Justin, but I think in social services, this is about as strong a piece of data as you're going to get. And so we can hem and haw about it, but geez, when I see this kind of data, man, we should be able to act on this. So what that action is, I think that's in a different form, but I think I think this is a thing, or about as clear a thing as you're going to get in social services data.
Personally feel like the data is clear about what has happened. What's not clear to me is I don't have the clarity of why or what that means. And it's an important enough issue for me. Before we take action, I need to make sure, or I would like to make sure that whatever mole we're hitting is the right one. And so maybe there's a group that wants to come together and have a conversation about what more do we need to explore around ED utilization and the causes for the drop. Because the drop in the data is clear. You're absolutely right, Justin and Rick. It's really clear. The drop has happened and it isn't what our first assumptions were.
Yeah,
And
totally.
maybe get together a small work group that says, what really does this mean and what really does it impact?
I do think, though, that if we could put our finger on that, it would probably be the New England Journal of Medicine article of the year, right? I mean, all of the problems in healthcare are death by 1,000 cuts, at least the complex ones. And I think the solutions are too, or the outcomes. And that's my take. I don't think we should shy away from the continued dialogue or the continued efforts to make sure that we can sustain the improvement. But just even as evidenced by the things that people are putting in the chat, I think that the collective take on this is probably many, many things, right? The availability of outpatient services, changes in consumer behavior, behavioral health resources in the ED, some things that the hospital did well, and so on and so forth. So, education, I think it'd be really hard to put our finger on this. And if we could, it would be literally a health affairs level article.
Yeah, I think I agree. But I think, it's less important to figure out the why as much as the fact that it is. So, I'm sure at some time the government used to buy tons and tons of horseshoes, and then cars came around, and, why people picked cars versus horses, I don't know, but they did. So they didn't keep buying 1 million horseshoes a year. They eventually said, we're going to buy tires. So I think if we're going to sit around and discuss it for years and years about why it happened, I'm sure there'll be 1 million great reasons. The bottom line is we're spending the same amount we've been year after year after year on a service that we are absolutely not utilizing the way we did year after year after year. As a group, there are a bunch of ways to redeploy those resources to help patients and to provide a better service in the community. I think that should be the conversation that's going on, I get it. It'd be great to know why. It'd be great to really know why on every little level and then replicate that. That'd be cool. But there are cars now.
I keep coming back to several years ago when we were, maybe it was at the start of the ACA expansion, when the ED measures and things, and we were trying to figure out within a year, we were expected to show something, and we were trying to figure out how are we even going to, at what point is it a 3-month pattern? Is it a 6-month pattern? Is it a 9-month pattern? At what point do we say, okay, we think this is the pattern? And I guess, and maybe that's what we hold ourselves to. At what point do we say, this is enough of data that we've had to we may never know all the whys, and it's probably a mix of a lot of things, you know, to Rick's point and to others. But at what point do we say, this is what it is? And we need to, so now how do we think about this? And knowing that this is what it is, looking at everything and saying, should we be looking at to do things differently? I guess, because we did that many years ago. We said, we're never going to know, you know, it's going to take a long time, but we were being forced to make certain decisions. And we just said, okay, 9 months is good enough. And this is, you know, and we have to make those decisions. So why are we not putting ourselves under the same type of, you know, should we be doing that? Should we be looking? I agree. I think the redetermination piece is going to be important too. But do we say, after, you know, a finite amount of time, we just have to accept this is what it is, and then make some decisions based around that?
So, and what I would throw in is that the quality of surety for making a management decision and making an academic decision are different. And so if you want to write your New England Journal of Medicine article, you're going to need way more robust information than this. But all of us who run organizations make management decisions based on weaker data than this. And so I think we need to accept that you make management decisions based on reasonably robust data, but you'll never have cause and effect for anything you do in management. And so I think this is one of those cases. So this is my take.
If I could, I'd like to add, while action discussions are likely to happen in other councils, work groups, contracting meetings, provider engagement panels are action locations for this kind of work. What we're proposing at this time is that the 1,000-foot elevation marker be that we evaluate ED utilization in Central Oregon based on maintaining the well-managed category. And other parts of this conversation will continue, I think, based on all of the things I just previously said.
Well said, Tricia. Thank you for everyone who's contributed to the conversation. It's been what I love best about this council, and it's definitely a way that we fulfill our mission, and to sit in each other's shoes and to listen to each other's perspectives. So I thank you. The conversation's not done, at least from my perspective. I know it's not from anyone else's, because it's just that important. So when it comes up, or we'll find a way to bring it up again in the correct context. And thank you both, Tricia and Justin and Rick, for leading us off into this. It's been a really great conversation.
Hey, real quick, Linda,
Yes.
sorry. Big thanks to that group as well. I thought in the last couple of years, we did an endorsement of these metrics as the monitoring metrics for the CCO for the year. We talked about that last month as targeting this meeting to do that endorsement. So I know it was listed on the agenda as info and discussion, but do we want to do a formal, a semi-formal? I didn't look to last year's minutes to remind myself what we did, but I think we have endorsed these in the past as our performance metrics that the board's going to monitor.
So you're asking for us to vote on the document that Tricia, the metrics that were presented last month, I think, and then presented in the spreadsheet?
I think
Is
we'd
that
like,
your request, Dan?
yeah, I guess you said it even stronger than I did. I was asking as a matter of protocol, isn't that what we did in the past? I thought we did, but to be more direct, I think it would be good if we established formally that these are our performance metrics for the year that we're going to monitor, since we have a habit of these coming on a quarterly basis. So.
What do people feel about that?
I think it's a great protocol for the board to be involved in setting these metrics and then formally endorsing them for the year. I think that's I think that's part of governance.
I agreed. I think too, with minus this last measure that we just spent a whole bunch of time, deep diving, all the others that we talked about make complete sense. And like, there was only really deep conversation on this one issue because we were trying to understand it so much, but the PCPCH and the behavioral health and all those things, like the description makes complete sense. So Dan, if you want like endorsement, I agree with you. I think we're fine. We're good to go.
That would help the CCO. And I do think it's a governance best practice.
Can I take that as a motion?
I think Dan made the motion, I seconded it, and Rick voted for it. So
it's probably one of those areas where I shouldn't make the motion because I represent the CCO.
All right, so Justin's made a motion.
I'll second.
There you go.
Rick has seconded. Question on the table, the board adopting the metrics for this coming year. All in favor? Opposed? Okay, motion passed. Thank you, Dan. Thank you, Justin.
Thank you.
Okay, moving on to the next agenda item, we have the CCO Health Equity Plan, and Beth James is here to present that for us.
Good afternoon, everyone. I'm Bess Jamie. I am the Social Determinants of Health and Equity Program Manager at I was going to say Peace Health. It's not Peace Health, it's Pacific Source. It's been a day already. And as part of my role and as part of the Health Equity team, I'm here to talk about our 2023 Health Equity Plan update for you all, and hopefully have a little time at the end for some discussion and conversation. Go ahead and advance the slides. So just to level set with everyone, I know many of you have probably had exposure to what our health equity plan is and what it's for, but essentially the health equity plan is a community informed plan. This is a 5-year plan that was developed from the community listening sessions that we did in 2019 and 2020. And every year we send the Oregon Health Authority an update. The foundation of our plan is built on the National Culturally and Linguistically Appropriate Services Standards, or the CLAS standards, which are a set of standards to guide healthcare organizations in developing practices that center health equity and really working towards eliminating healthcare disparities. So as part of our reporting to OHA, we have projects in, sorry, go ahead and next slide. We have projects in focus areas that are internally facing to improve our work as a CCO, and externally facing to improve the health of our members and communities. And I'm going to highlight a few projects from these 3 focus areas today. It's important to note that OHA is the body that identifies the focus areas for the CCOs to work on. And every year we sort of get an updated list based on some of the OHA priorities and things that they would like to see improvement on across the state. So today I just want to highlight some successes that we've had in the past year around improving our approach to our grievance and appeals process, language access, and member communications using plain language and alternative formats. So next slide. First of all, I just want to share in terms of grievance and appeals, or complaints and appeals, we've had a couple of great accomplishments in the last year where we've been able to create and launch a training for traditional health workers to support members in filing complaints and appeals. We know that for folks that may not have experience interacting with the CCO or with the health system, that filing a grievance or appealing a decision may feel daunting, and we wanted to try to lower the barriers to entry for that by helping to train some of our grassroots level staff that work directly with members to help them navigate that process. We also created a way for community members to submit anonymous feedback to Pacific Source through our website so that we could hear their feedback in a way that, that they didn't have to attach their name to or feel any kind of like their identity would be exposed. So that image there on the slide is a screenshot from our website on ways members can submit feedback to us. And we're already getting some really good things, and we'll be sort of funneling that feedback to the various departments that where they can take action, make decisions, and improving our service to our members. Next slide. So I want to point out that, again, this work was influenced by what we heard from the community. And so, we work with the CCO Community Advisory Councils to review documents from time to time. So we've been working with the CACs over the last year or so to review and suggest edits to documents for our members. We've also have an upcoming training for providers on using plain language in both written and verbal communications as a way to really improve health literacy for our members across the system. So we're excited for that work, again, sort of lowering barriers to entry and making sure people understand what their benefits are and the services that they can access. Next slide. And then just quickly, 3 other projects that I wanted to share with you, again, influenced by community feedback. I think as you'll see going forward, there's a focus area for 2023 from the OHA specifically around community engagement. They really want to see the voice of members influencing the work that we're doing and having, a stake in how we proceed with the services that we provide. So this is just a quick snapshot to give the council an idea of the work that we're doing internally to make sure we're responsive to emergent needs that come through our membership. So similar to what I was sharing before about our grievance and appeals process, we created a video in plain language, Spanish, and American Sign Language to explain how to file a complaint or appeal with us. Just again, to take the language to a level that everyone can understand and see what the process is for doing that. When we had a slate of new Afghani arrivals in the state after the U.S. pulled out of Afghanistan, there was a demand there to create member materials in Farsi, Dari, and Pashto to serve those new arrivals and to make sure that they had access to interpreters and could get the care they need in their language. And then we also updated our contact information on our website and all of our member materials to include the phrase, "We accept all relay calls," to better serve our members who are deaf or hard of hearing. And that's important in distinction because the technology that signals to the deaf and hard of hearing community that we have the technology available to speak to them through video or through relay, and it doesn't, it lowers the barrier to someone who is hard of hearing speaking to us on the phone. All right, next slide. So turning our eye towards 2023, the new focus areas that have come down from OHA that we'll be creating some strategies, goals, and projects around are to serve a couple of priority populations that they're calling out explicitly, and that is people with disabilities and people who identify as LGBTQIA2S. And if you're not familiar with the 2S part of that, it's Two-Spirit. And more, the LGBTQ community is wide and large, and we want to make sure people feel included and seen as part of our plan and our membership. And then, like I mentioned, the community engagement activities, really prompting CCOs to reach deep into the communities, elicit feedback, get input, do some power sharing and co-leading of spaces so that this is not a top-down approach with regard to health equity and our health equity plan. We really do want to involve members. And I hope I've shown you at least so far that we've been doing it all along. It's just that we know that we can continue to improve in that area, and community engagement takes intention and time. And we know that sometimes we can get really wrapped up in our own work. And so we just need to pause and make sure that we're creating space for those conversations. And next slide. So if we look with a little bit closer focus to the priority populations around what the goal is for including this focus area in our health equity plan, OHA really wants us to create systems and processes that provide effective, equitable, understandable, and respectful care and services to people with disabilities, people who identify as transgender, non-binary, or gender diverse, and people with sexual orientation diversity, or those that don't identify as straight or heterosexual. And next slide. And then again, with community engagement, the goal here is to work with the community to improve health outcomes by working together to guide projects and activities and collaborate with cultural community partners specifically. I just want to do a big shout out to our health council partners, our CCO director, our community health coordinator, our THW, and health equity liaisons. These are folks working in the community every day that we rely on to, really help us elicit that feedback and influence the work that we're doing. So just deep appreciation for that work. It takes a lot of time and intention, like I said. So just really excited about what's ahead. Okay, and last slide, actually, this is, I know I don't have much time to discuss this with you, and I'm happy to come back. I'm sure Martha Edwards, who you met earlier, is happy to come and have this discussion more fully, but just some food for thought and maybe a minute or two where I can open the floor to hear any ideas or questions, but really just looking for, opportunities you might see for us to improve our community feedback or engagement process, specifically around projects that will impact health equity. We're also looking for ways that we, the CCO Health Equity team, can support your efforts in that area. So thinking about that. And then are there any health equity concerns specific to the Central Oregon region that you would like to share about our new priority populations? Is there anything that you want to surface for us that we may not have visibility into that we should consider when we're kind of building out our plan or our goals around serving these priority populations? So just some questions for thought, and then I just want to open it up to your questions, your thoughts, any feedback, and just appreciate your time today.
Thank you, Bess. Are there any thoughts or comments from the group? It's a great presentation. Bess, are there other groups? You mentioned a couple of groups that have already received this presentation. Are there others that you have targeted to share this information with here in the region?
Oh, other than the CAC, who will be presenting to next week, I believe. I don't think anything is on the calendar, but we are always happy to come to any table that invites us or would like to hear more. Any health equity coalitions, any culturally specific community groups that you think might be interested, just give a shout out. Martha Edwards is your health equity liaison in Central Oregon. She is available and around and happy to make that connection. So
good. Well, I'm glad to hear that you're going to be sharing this with our CAC. And Carmen?
Yes. Yeah, I just really quickly, Bess, thank you for all this work and being intentional about health equity. And as we lean into our regional health assessment, which was presented earlier, how can we intersect our efforts together and deepen those relationships and communities? So that would be great to do something in that pathway.
Yeah, agreed. Thanks for that, Carmen. Alignment with the community health improvement plans is certainly a central focus for our work broadly.
Martha, did you have something you wanted to add? I saw your light go on.
No, just that, yeah, I will be presenting at the CAC meeting next week.
Good. I will see you then. Thanks again for the heart and the commitment that you guys bring to this work because it's so important.
Thank you. Good to be here.
We'll see you next week. Our last agenda item for the day is a report from Kristen O'Connor on Connect Oregon program. Kristen?
Yes, thank you for having me today. My name is Kristen O'Connor. I am the Customer Success Manager here at Unitas, also known as Connect Oregon, who works closely with the Pacific Source team in general, but also certainly in the central region. So I thank you for allowing me to steal some spots on the agenda today. I can share my screen. So I was just going to provide a high-level overview of what Connect Oregon is, how it works, let everyone, particularly in this group, know that it's available in this community. And so I can probably cruise through quickly because I know we're almost at the end here. But just as like a super high level overview, so what is Connect Oregon? Connect Oregon is a coordinated care network of healthcare and social service providers that come together to be able to deliver integrated whole person care through our shared technology platform. So Unitas is the technology platform, the software platform that enables the Connect Oregon network of healthcare and social care providers to be able to send closed loop electronic referrals amongst each other for folks that they are working with. So through Connect Oregon, network partners have the ability to make, as I said, the closed loop electronic referral, securely share client information and track those outcomes together. So, you know, what happens when you make those referrals? Are they resolved? Do folks actually get connected to care? And ultimately, the data that we gather can inform community-wide discussion. So whether that's around, you know, what service types are most utilized in a community, where capacity increases or services are needed, any gaps in the resources that are available in a community, and really anything else that we're able to gather from the data. So what's important to note, though, is that Connect Oregon is provided at no cost to all community-based organizations, community health centers, federally qualified health centers, and healthcare providers that are contracted with our CCO partners, in this case being Pacific Source. Little high-level overview. So within the state of Oregon, we're currently officially live in all 36 counties. We just updated this slide to reflect that Unitas is available now in Hood River and Wasco counties, which were the last two that had yet to launch. So we've just had some new network activity there, which is great. You can see who our partners are here along the bottom. We are connected primarily through the coordinated care organizations in the state. So those are the majority of our funding partners, and we also partner with Kaiser Permanente. So in launching the Connect Oregon network, you know, the state really hadn't made a statewide determination on what the operating system would be for community information exchange. So the CCOs took it upon themselves with guidance and direction from the Oregon Health Leadership Council to identify and partner with Unitas. So we are now truly officially a statewide network. Just a high level overview here. So this is just a snapshot from February of sort of where we are statewide. So statewide, we have over 1,000 organizations that have joined the Connect Oregon network. That was encompass over 2,100 individual programs within those organizations. And of those, about 1,100 are configured to receive referrals. Typically, when folks join, like healthcare providers, mental health providers, they'll typically join with the intention to send out referrals as they're working with patients, clients, and identify social care need. And the CBOs tend to join with the intention to receive referrals, but that can go either way, both ways, really depends on the organization. Here we have just a high level overview of where we're at in the central region. So Deschutes, Crook, and Jefferson counties. This is from March. So currently we've got 92 organizations that have joined over the past 3 years, capturing 163 programs, and almost 70% of those have been configured to receive referrals. You can see that individual and family support is at the top there, followed by mental, behavioral health, physical health, and wellness in terms of service types. And I'll cover the service types in the next slide here. So why are we here? Ultimately, it's because service providers are fragmented. Co-occurring health and social needs are often under-addressed across the community since providers are disconnected, folks are using different systems that don't speak to each other. So healthcare and social care providers lose visibility after patients are discharged.
Vulnerable patients seek clinical care for social problems, causing unnecessary utilization of healthcare services, emergency rooms, for example. So Unitas is the technology platform that facilitates that closed loop referral. And that way, that means, senders have visibility into the outcomes of those referrals using our platform. Just a alphabet soup is what I like to call this slide. So Connect Oregon Unitas, we enable secure, meaningful information exchange across sectors. So Unitas is HITRUST, SOC 2 Type 2, and NIST certified and follows the highest security framework in the industry. We are HIPAA compliant and fully aligned with strictest federal privacy regulations, including 42 CFR Part 2 for FIRPA and FIPS, so you can easily and securely share client information. We are also hosted by AWS and have fully certified and compliant cloud servers, so all of our data centers are located within the US. Terminology here, just some high-level overview of these high-level service types that you'll find within our platform. Underneath each of these high-level, there's multiple subtypes within that different organizations or programs can really specialize in, fall within. So physical health providers, that can be any PCP clinics, specialty clinics, mental health, behavioral health providers. Food assistance is one of the highest utilized service types generally in the state. So, emergency food, prepared meals, meals on wheels, benefits navigation with regard to like SNAP and WIC benefit assistance. Individual and family support is usually one of the highest service types as well. So that's a broad service type that it can include, disability support, home visiting programs, life skills trainings, different things like that. So yeah, housing and shelter is a little bit trickier to solve for, as I'm sure everyone's aware, but transitional housing, homeless drop-in services, home repairs, and then rent and mortgage and payment assistance. And then in the center here, emergency one-time financial assistance. I did want to note that because as of the end of December, providers and CBO partners that are part of a member's care team can now submit flex funds requests to Pacific Source for approval via Unitas. So the goal is to really streamline those requests. So that is a service type that can be utilized for a Pacific Source member that is needing flex services. So if it's rental assistance, mortgage assistance, if they have chronic asthma and they could really benefit from an air conditioner, things like that. So that was an exciting update that took place right at the end of last year.
Kristen, can I just lean in here in a way that, just to clarify, the flexible services is administered by Pacific Source specifically. It's member level investments. So we literally track each ID attached to these investments. And oh shoot, I lost the important part. Why I unmuted. And so I think we're just going to go with that at this point. So, and they're non-covered services. There it is. Thanks for staying with me.
Thank you. Yes. So just to note too, absent the flex funds requests that are specific to Pacific Source members, otherwise any particular insurance type is not a factor in being able to add someone to Connect Oregon or connect them to services using the platform, with the exception of the flex services that would go directly to Pacific Source for approval. In that case, that person would have to be a Pacific Source member, but that is the only service type that is specific in that way. Okay, connecting people to care. So I'm going to do a high level overview of sort of this flow of how it would work. So in this example that I have here, Sue is working with Tom at her organization. She screens Tom and identifies he has additional social care needs, such as food assistance needs or utility bill assistance, or really any other service that Sue's organization does not provide. So Sue can log into her Unitas account, check to see if Tom already has a profile, if he's already been added to the network by searching first name, last name, date of birth. If he has not been added to Unitas by another community partner yet, she can quickly create a profile for him, capture his digital consent to join the network, which consent only has to be captured one time. So not per referral, and someone can rescind that consent at any time if they so wish. And she can then send a closed loop electronic referral for Tom to one of the one or multiple community partners that have also joined the platform. So you can send a pooled referral as an option, meaning, let's say it's an emergent need and you want to cast a wide net, you can send the same referral to, let's say, 3 organizations who provide the same services. And then it kind of acts like Uber or Lyft, where the very first organization that accepts that referral, it'll drop it from the other 2, and you don't have to go back in and do any additional administrative work or anything like that. So through the platform, she can seamlessly communicate with the other providers in real time via the notes section. We're also going to be launching user-to-user messaging soon within the platform as well. And yes, so she can have, real-time access and information to when Tom receives that care, and really kind of be part and track his total health journey. And then, oh, there we go. So I wanted to provide for this group just a high-level overview of sort of the origin of Connect Oregon in the Central Region. And that Connect Oregon, the network launched in the Central Region via sponsorship by the Central Oregon Health Council in September of 2022. So that initial launch included 18 in-network partners, and I can run through really quick, but those being the Ben Redmond Habitat for Humanity, Bethlehem Inn, Housing Works, Deschutes County Health Services, Family Kitchen, Friendometry, Full Access High Desert, Burnish Hope, Habitat for Humanity, Halion House, High Desert Food and Farm Alliance, Lapine Community Kitchen, Latino Community Association, Mosaic Medical, Mountain Star Family Relief Nursery, Neighbor Impact, St. Charles Health System, the Giving Plate, and Volunteers in Medicine. Just to highlight those initial orgs that joined. And then as time progressed, as of July 2021, Central Oregon had 21 in-network partners and had supported 417 clients with 616 referrals. Then COVID came around. So in January 2021, Deschutes County started using Connect Oregon for COVID wraparound referrals. That obviously came with some enhanced funding to help address the public health emergency. So wraparound support, refers to any service provided to a COVID case in order to help facilitate successful isolation or quarantine. So is that motel rooms for isolation or groceries, food delivery, rent, mortgage, utility assistance, connecting folks to wage replacement programs, other safety net providers. Through Q2 21, we onboarded additional clinical users and providers in Deschutes County through the pilot. And then August 2021 and beyond, we expanded into Jefferson, Crook, and Northern Klamath counties through partnership with Pacific Source. I just have a slide here just like highlighting the COVID wraparound services. So starting in February 21, Unitas worked with 3 local health departments, so Deschutes County, Marion County, and Clackamas County, to provide technology training and technical assistance in order to securely and effectively connect individuals who needed wraparound services to maintain quarantine or isolation with community-based organizations using the Connect Oregon network. And within 4 days of that launch, saw an average case resolution of 87% and referral acceptance rates of 98%, which is pretty spectacular. So it was indicative of an efficient collaboration to help those in need, which was awesome to see. And then I just included some of our data models, just some definitions of the data that we track within Unitas as a helpful guide for anyone who looks at this next slide here. So this is sort of where we are to date from really launching technically in September of 2020 through March 1st here. So in total, almost 1,500 individual clients have been served using the Connect Oregon network, almost 3,000 cases. So a case, when someone makes a referral and it's accepted, it becomes a case, but also organizations can create their own internal cases. Some CBOs can use Connect Oregon sort of as their own case management tool, for example. So yes, and then a referred case there is indicative of a referral that became a case. So we've had great usage of the platform up to this point. You can see that individual and family support there is by far the highest utilized service type in the region. And so that's followed by housing and shelter, utilities, clothing and household goods, and food assistance. So yes, there's currently roughly about 90 organizations that are on the platform. So moving forward, just looking to support all the organizations that have already joined. One of the perennial needs with Connect Oregon is perpetual training, because folks, they leave positions at jobs, organizations. Sometimes there's a super user, and when they leave, they'll take their Unitas knowledge with them. So always just trying to connect and support folks who are on the platform. Currently, supporting certain referral pathway opportunities. If one organization really needs a defined pathway with another community partner, sometimes that's a great way to get them to join for like a specific referral pathway opportunity. And then once they're on the platform, they see all the other ways that they can use it. So yeah, really just wanted to make sure everyone is aware of Connect Oregon, and that I'm also here for any any needs, any questions anybody has. If anyone is interested in joining, I'm happy to provide presentations and demos if anyone is interested. And that was
Thank you, Chris.
that was my rapid presentation.
Thank you, Kristen. Any thoughts or questions of Kristen? Well, I
This is
want to
Brad.
thank you. Oh, go ahead, Brad.
Yeah, I just want to shout out as one of the organizations that used Unite Us Connect Oregon during COVID for wraparound services. It was a fantastic tool. Our staff across the board really enjoyed using it and found it a great way to be directly linked to our health department in Deschutes County. Jefferson County didn't use it, and I don't remember if Crook County did, but Deschutes County did. And that's where most of the cases were. So it was useful, and I think, I mean, as far as like from a user perspective, if it could do everything we needed it to do for our organization, we would use it. It's very user friendly, and it has that closed loop referral system, which I think every, really business, but nonprofits in particular have been wanting forever. So, thank you.
Definitely.
And thanks to the Health Council for supporting that, paying for it.
Yes. And then if any organization that you know of, you think would be interested, you can definitely send them my way. My contact information is included in that packet. And then really steps to join is just an organization would complete a partner registration form, outlining the services they provide. Even if they're just sending only, it'll be what's listed on the platform. And then it takes about 10 business days for our team to build that organization. And then we'll reach out, do platform training, and then live and good to go. So very, very simple to join.
Thank you, Kristen. I appreciate it. It's not often we get a chance to see a project that the Health Council sponsored initially and where it's come in a relatively short period of time. And the other thing I love about this project is that most people, and myself included at one time or another, when we come to a health provider, part of it is paid for by insurance and is medically related. And part of the issue is not solved until I get a non-medically related, non-billable service. And what your role has been is to really make that easy for providers to find and arrange for the total care for an individual based on what they need, and to connect people in the community easily to the providers who do that. So it's a great form of community engagement. Thank you so much for your leadership.
You're very welcome. Thank you.
And is there anything else for the good of the order today?
Just a quick reminder for everyone that I believe our next meeting will be in person. And is it Madras, Camille? Okay, in person. And if everyone would kindly RSVP to her for logistics and food orders, that would be appreciated. Thank you.
And Carmen, thank you for reminding me at the very beginning of the meeting. I was supposed to mention that the board retreat has been scheduled for Thursday, June 8th. So if you could map that out on your calendars, put a placeholder there, we'll fill you in on more information about time and location. Thank each of you for staying through to the end. It's been a great conversation from my perspective, and I just so enjoy working with each of us and just being a part of this great effort. So if we are concluded, we'll call meeting adjourned. Thank you so much. Drive safe. Divya, did you have your hand raised, or were you saying goodbye? Just goodbye. Drive safely if you have to drive from where you are home.